Hello everyone, my name is Seung-Hyup Kim, Professor of Radiology at Seoul National University Hospital. In this session, I would like to share my experience of MRI evaluation of ovarian masses with pattern recognition approach. This is a photo of a reading room of genitourinary section of Radiology Department of Seoul National University Hospital. When I am teaching my residents and fellows, I always bring a memo paper and I have a habit to draw a schema when I am explaining imaging findings of an ovarian mass. This kind of schematic drawing is much better than verbal explanation only. And so I collected these schematic drawings and tried to use them in this talk explaining the MRI findings of ovarian masses. I think this is something like this kind of matching process of similar patterns of faces of brothers or sisters. Let me show you an example. Here is a 50-year-old woman with an ovarian mass, unilocular cystic with a mural nodule. And here are 4 more different cases with a similar pattern. Maybe we can draw this pattern like this schema. Unilocular cystic mass with 1 or 2 mural nodules, and an important point is that the surface of these mural nodules is quite smooth. This pattern is quite characteristic of clear cell carcinoma of the ovary that belongs to epithelial tumor category. To do this kind of pattern recognition approach well, we should be familiar with the whole spectrum of categories and the individual entities of ovarian masses. We can categorize them into 3 groups: functional cysts, non-neoplastic masses, and ovarian neoplasm. And we should be familiar with those subgroups and individual entities belonging to each group. So the role of imaging in ovarian masses is first detection and then characterization. First, we should divide them into neoplastic and non-neoplastic masses. If it looks like a neoplastic mass, then characterize it as benign or malignant. And if it looks like a non-neoplastic mass, then characterize it as functional cysts or other non-neoplastic masses. In this process, our goal is to approach more specifically, if possible. Before going into individual groups, let's think about difference of patterns between neoplastic and non-neoplastic cystic ovarian masses. It is well known that neoplastic masses usually appear as a single cystic mass with thin outer wall and multiple septa, so-called multiseptated cystic mass, while a non-neoplastic lesion usually composed of multiple conglomerated cystic masses with thick outer wall. If we explain the difference of these findings with these schema, probably it will be much easier to understand and easier to memorize. This is a case of borderline mucinous tumor having this neoplastic pattern, and this is a case of endometriosis having this non-neoplastic pattern. These articles reported that subjective evaluation with pattern recognition is superior to multiparametric models such as scoring system, and diagnostic performance of pattern recognition improves with the increasing level of experience. Now let's begin with functional cysts group. Common entities are follicular cyst, corpus luteal cyst, and thecal lutein cyst. Their patterns are like these: thin-walled unilocular, thick-walled unilocular, and thin-walled multilocular. Among them, corpus luteal cyst usually has thick hypervascular wall, and it shows strong contrast enhancement at CT or MRI, and hypervascularity at Doppler ultrasound. This finding at Doppler ultrasound is called ring of fire. The most important characteristic of functional cysts is that they will change on follow-up. Follow-up imaging 6 to 12 weeks interval is recommended. Here is a thin-walled unilocular cyst, most likely a follicular cyst, and it disappeared after 10 weeks. Hemorrhage occasionally occur in functional cysts. They have reticular, lace-like, or fishnet appearance due to fibrin strands, and retracting clot may mimic papillary tumorous growth. Doppler ultrasound will show that there are no flow signals in the clot. Intracystic hemorrhage usually regress spontaneously in 30% within 2 weeks and in 100% within 8 weeks. Here is a large hemorrhagic cyst with clots and fluid level on MRI, and there is no contrast enhancement of the clot at fast-suppressed contrast-enhanced T1 weighted image. Follow-up ultrasound in 1 week and 4 weeks show spontaneous regression. This is a case of hemorrhagic corpus luteal cyst and shows heterogeneous signal intensity at T2 weighted image due to hemorrhage and thick wall with strong contrast enhancement. And ultrasound shows heterogeneous intracystic echoes, and follow-up ultrasound in 6 weeks shows spontaneous regression. Now, next category is non-neoplastic lesions, and typical example is endometrioma. Imaging features of endometrioma are variable and nonspecific, but basically they are multiple thick-walled cystic lesions with diffuse low-level internal echoes, so-called ground glass appearance. And in about 30% of cases, we see echogenic mural foci as in these cases. Here are 4 different cases of endometrioma, and the common ultrasound finding is thick wall and ground glass internal echoes. We may see similar findings in mature cystic teratoma, hemorrhagic ovarian cyst, and tubal ovarian abscess as well. There was an article entitled Acoustic Streaming in Ovarian Cysts. Acoustic streaming is a sign at real-time ultrasound representing continuous movement of echogenic particles within a cystic mass due to ultrasound power. In endometrioma, we do not see this phenomenon because of high viscosity of thick chocolate-like contents of the endometrioma. I believe this phenomenon is useful in differentiation between endometrioma and hemorrhagic cysts. To confirm the diagnosis of endometriosis with imaging, MRI is the best way. MRI findings of endometriosis is characteristic, and they are high signal intensity T1 weighted image, of course, which is not suppressed at fast suppressed sequence, and markedly decreased signal intensity at T2 weighted image. This finding of signal decrease at T2 weighted image is called T2 shading. That is caused by high concentration of protein and iron by recurrent hemorrhage. Here is a case of endometrioma in a 16-year-old girl, typical T1 high signal intensity and T2 shading. In addition, we see dark signal intensity spots in the dependent portion of the mass that does not show enhancement after gadolinium injection. Ultrasound in this patient shows echogenic lesion in the same location, which probably represents retracting blood clot. There was a nice article reporting the value of this MR finding, T2 dark spot sign, in differentiation of ovarian endometrioma from hemorrhagic cysts. They found that this T2 dark spot sign has high specificity but low sensitivity, while well-known T2 shading sign has high sensitivity but low specificity. It means that these two signs are complementary to each other in differentiation between endometriomas and hemorrhagic ovarian cysts. Another important thing about endometrioma is that a malignant tumor can develop in the cyst wall. That is why we need to be careful if we see a mural nodule at ultrasound. Here is such a case of endometrioma, a large mural nodule at the cyst wall, but no enhancement of the lesion at contrast-enhanced subtraction image. So it is a case of large endometrioma with large blood clot. Here is another case of endometrioma with multiple mural nodules, but in this case, these nodules are well enhanced at contrast-enhanced subtraction image, and it was a case of endometrioid carcinoma developed in the wall of an endometrioma. Now let's move on to ovarian neoplasm category. On the basis of presumed cell origin, ovarian tumors are classified into epithelial cell tumors, germ cell tumors, sex-coat stromal tumors, and miscellaneous tumors. One thing unique to ovarian neoplasm is that there is a category of borderline tumors in epithelial cell tumor category. Epithelial tumors account for 60 to 70% of all ovarian tumors and include two most common subtypes, serous and mucinous, and other less common subtypes, endometrioid, clear cell, Brenner, and undifferentiated carcinoma. First, serous tumors in epithelial tumor category. It is the most common epithelial tumor with malignancy rate of 25% and borderline in 15%. Bilateral cases are 20% in benign and 50% in malignant cases. Typical patterns are unilocular or bilocular cyst without solid portion for benign serous cyst adenomas, mural papillary growth along the cyst wall in borderline serous tumors, and bigger and irregular solid parts mixed with the cystic components, or sometimes totally irregular solid masses in serous cyst adenocarcinomas. This is a pattern of serous cyst adenoma, and this is a case. This is a pattern of borderline serous tumor, and this is a case. This is another case of borderline serous tumor having this pattern. One thing we should keep in mind is that rarely small papillary mural lesions can be seen in benign serous cyst adenoma, as in this case. These are two different cases of serous cyst adenocarcinoma showing mainly solid or totally solid patterns. Now the second most common epithelial tumor category, mucinous tumors. Its size is larger than serous tumors. Rate of malignancy and borderline tumor is 10% each, which is lower than the rates in serous tumors, and bilateral in 2 to 5%, also lower than serous category. These are patterns of benign mucinous tumors, multilocular cystic mass with thin septa and various contents of locules. These are patterns of borderline mucinous tumors, also multilocular cystic pattern with slightly thick or irregular septa, or less commonly a pattern of unilocular cyst with papillary mural nodules, which is exactly the same as the pattern of serous borderline tumor. Malignant mucinous tumor has this pattern, complex multilocular cystic pattern with thick and irregular septa and solid nodular lesions. These are patterns of mucinous cyst adenomas, and these are cases. Sometimes mucinous cyst adenomas have oligolocular pattern. It means unilocular or bilocular, but still we can see locules of various signal intensities or internal echoes. There are two pathologic subtypes in mucinous borderline tumors, more common intestinal type and less common endocervical type. These two subtypes have different imaging patterns. Intestinal type has this pattern, multilocular cystic pattern with slightly thick and irregular septa, while endocervical type has the same imaging pattern of serous borderline tumors, unilocular cyst with papillary mural nodules. This is another case of mucinous borderline tumor, intestinal type, and this is a gross specimen. This is a pattern of malignant mucinous tumors, mucinous cyst adenocarcinomas, and These are two different cases showing complex septa and solid nodular portions. Imaging pattern of endometrioid carcinoma is nonspecific, with variable cystic and solid components, or sometimes mainly solid as these schema and cases. Now another tumor in epithelial tumor category, clear cell carcinoma. Its pattern is known as a unilocular cyst with solid protrusions. Because frequently solid protrusions are few in number, just one or two, with smooth margin, I drew schema like this, and this is a case. Here is another case of clear cell carcinoma of this pattern, and here is again another case with the same pattern. If solid portion becomes large, imaging findings become nonspecific, in other words, become similar to other epithelial neoplasms. Two different cases of clear cell carcinoma with relatively large solid portions, difficult to suggest clear cell carcinoma, but probably still you can feel that these solid protrusions have relatively smooth surface. Now let's move on to the next category of neoplasm, germ cell tumors. This category is tumors of young women, accounting for 15 to 20% of all ovarian tumors. In teratoma group, most common are mature cystic teratoma and others are immature teratoma. There are other malignant germ cell tumors, including dysgerminoma, endodermal sinus tumor, embryonal carcinoma, choriocarcinoma, and more commonly, malignant mixed germ cell tumor. Imaging patterns of those germ cell tumors are very variable, like these schematic drawings. Mature cystic teratoma is the most common germ cell tumor, composed of all three germ layers. Bilateral cases are quite common, between 8 to 15%. Mature cystic teratomas are usually unilocular cystic tumors filled with a sebum, which is liquid at body temperature. Cyst wall is lined by keratinized squamous epithelium. Mural nodule that contains bone, teeth, or hair is called Rokitansky protuberance or dermoid plaque. Ultrasound features of mature cystic teratoma are mottled or streaky echoes or fluid level within a cystic mass, and dermoid plaque appearing as an echogenic mural nodule with posterior shadowing. Here are 4 different cases of mature cystic teratoma showing various ultrasound features, but common finding is strong echogenicity within the mass. Here are 3 different cases of mature cystic teratoma showing interesting findings of dermoid plaque, entangled hair floating at fluid level, and multiple floating fat balls. This is a case of large mature cystic teratoma composed of multiple cystic masses of various imaging patterns. Sometimes mature cystic teratoma looks like a purely solid mass at ultrasound, and in those cases it will be difficult to make a correct diagnosis. However, in those cases, we usually see hypoechoic or anechoic halo around solid-looking hyperechoic mass. This hypoechoic or anechoic halo represents fluid around the solid portion, and we reported these findings in 1999. This is a case in the journal. We see a solid ovarian mass with a peripheral thin anechoic area representing fluid layer. T1 and T2 weighted MR images indicate that this layer is non-fatty serous fluid, and gross specimen shows gap between solid mass and tumor capsule where fluid was located. Here is another case of solid appearing mature cystic teratoma with the same finding of peripheral anechoic layer, and the CT shows that this layer is fatty fluid in this case. So this peripheral fluid can be either fatty or non-fatty fluid. As you have seen, echogenicity of fat, which is a hallmark of mature cystic teratoma, is variable. This ovarian mass has two areas, hyperechoic dependent portion and the hypoechoic non-dependent portion. Because of this echogenic area, we may suggest mature cystic teratoma, and probably many of you expect this echogenic area will be fatty portion of the teratoma. However, MR images clearly show that this hypoechoic area represents fatty fluid, and this echogenic portion represents hairball mixed with fat. Here you can see a thin layer of non-fatty fluid in non-dependent portion around this hairball. So we should keep in mind that fat is not always hyperechoic, and echogenicity depends on heterogeneity of acoustic property. Now, next tumor we should think about in germ cell tumor category is immature teratoma. It is a tumor of younger patients and is a teratoma that has immature or embryonic tissues. Dermoid plaque in immature teratoma as compared to that in mature teratoma is large, irregular, and shows strong contrast enhancement, and it often has calcifications. Another tumor in germ cell tumor category is dysgerminoma, which is the ovarian counterpart of testicular seminoma or brain germinoma. This is a schematic pattern of dysgerminoma, lobulated solid mass with fibrovascular septa, and this is a case showing fibrovascular septa very well. The third category of ovarian neoplasm is sex-cold stromal tumors. This tumor accounts for 5 to 10% of all ovarian tumors. It's usually unilateral and often with hormonal activity. The most common of this category is fibroma, fibrothecoma, thecoma group, and next common is granulosa cell tumor. And there are other rare tumors, including Sertoli lady cell tumor and sclerosing stromal tumor. And these tumors have these imaging patterns. Fibroma, fibrothecoma, and thecoma appear as well-defined solid masses with various degree of contrast enhancement. This tumor appears as a homogeneous mass with sonic attenuation at ultrasound, and characteristic MRI finding is predominant low signal intensity on T2-weighted imaging because of abundant collagen tissues. This tumor can accompany ascites and pro-effusion, and then the condition is called Meigs syndrome. Granulosa cell tumor is low-grade malignancy and is the most common estrogen-producing tumor of the ovary. Most common imaging pattern is multilocular cystic mass composed of innumerable small locules with frequent fluid levels due to intracystic hemorrhage, so-called sponge-like or honeycomb appearance. This is a case of granulosa cell tumor showing this imaging pattern. Now, last category of ovarian neoplasm is miscellaneous tumor category, including metastatic tumors and lymphoma. 80% of metastatic tumors are bilateral, and they are commonly from gastric or colon cancer. They usually have smooth margin and keep oval configuration, and the imaging pattern depends on primary site. Typical imaging pattern is like this schema, mainly solid with intratumoral cysts, especially in metastasis from gastric cancer. And this is a case of metastatic tumor from gastric cancer showing this pattern. Here is another case of metastasis from gastric cancer showing this pattern. But we should keep in mind that imaging pattern of metastasis from colon cancer is quite different and frequently shows multilocular cystic pattern. This is a case of metastasis from sigmoid colon cancer showing this pattern. Another case of metastasis from rectal cancer showing this multilocular cystic pattern. I think you probably feel the difference of this pattern from multilocular cystic pattern of mucinous tumors. So, I would like to finish this talk by mentioning that if we are familiar with the whole spectrum of ovarian masses and their characteristic imaging patterns, we may be closer to the correct and specific diagnosis of ovarian masses. Thank you for joining this session, and if you have any questions, please email me.